Hello, this is Dr. Laura Tigler. Welcome to my channel. This channel is meant to provide good general medical information. It's not meant to provide specific medical advice. Please do see your primary care provider or your doctor to obtain medical advice that's tailored specifically for your needs. At the end of this channel, I will provide some spiritual information. If you do not want to see that portion of the video, once the medical information portion is finished, I will let you know. At that point, you can simply click away. But first, please do like and subscribe. Today's topic is palliative referral, what it is and when it's appropriate. So I am going to share my screen today. Let me go ahead and get that started for you. Okay, this is a very busy table, and we will get to that. But I want to go over some information for you first. Okay, so palliative care, the referral is appropriate if you want to prevent and relieve health-related distress. It has a patient-centered approach, and it's specifically for symptom relief, also to improve quality of life. Notice how I did not say quantity of life. So when we're doing a palliative referral, our primary goal is not to lengthen the lifespan. Our primary goal is to improve the quality of life and relieve symptoms. So core principles of end-of-life care include respecting a patient's autonomy. And that's what I meant about a patient-centered approach. We really need to perform interventions or give treatments that the patient is fully aware of and agrees with, and it's a plan that they themselves agree with. And then, like I said earlier, we want to promote symptom relief. Conditions that may be related to a palliative referral include cancer, organ failure, and that could be heart failure, kidney failure, for example, if someone's on dialysis, or lung failure, like a COPD patient that's at the end of their life. They're on oxygen 24/7, and they can't breathe if they just move 2 steps. Dementia, a common example would be Alzheimer's dementia, but there are several other types of dementia. Amyotrophic lateral sclerosis, or ALS, not too common or as common as the conditions I've mentioned, but still a very serious condition and one that is appropriate for palliative care. And stroke. So treatment decisions, they should reflect the patient's goals. And so we want to give a list of the pros and cons for the treatments, and we want to give a list to the patient of options, including doing nothing. Quality of life, like I said, that's top of mind for palliative care. And we want to limit adverse effects and also limit treatment burden for the patient and the family. So we manage symptoms. I'll give you some details on that. A common symptom might be loss of appetite. Another common symptom might be impaired secretion clearance. Let's say the patient has cancer, it's metastasized to the lungs are filling with fluid. The patient has a cough, let's say with COPD, or an increased productive cough, trying to get the phlegm out. You can imagine there are many conditions with secretions or fluids that need to be managed. And we want to limit unnecessary interventions. So the patient or their advocate can say to the provider or doctor, is this medication really necessary? And perhaps before the palliative referral, the medication was necessary, and everyone agreed it was necessary. But now that they're in the palliative care, they're rethinking their goals. And they might, you want to go over the medication list again and again, pretty much at every visit would be my ideal. And then ask, is this medication or even treatment still necessary? Like, let's say a woman is getting an every 6-month shot or injection for osteoporosis, yet she might have 6 weeks left to live or 6 months left to live. Of course, we're going to do fall precautions. We don't want her to have a fracture related to the osteoporosis, but let's say the medication that she's taking is very expensive. That's a treatment burden, or it's giving her side effects. So she is going to have to make a decision as to whether or not she really wants to continue with that medication. We want to manage nausea, constipation, dysphagia, which is difficulty swallowing, reflux of acid, dyspepsia, which is upset stomach, which could be from a multitude of reasons. Vertigo, very common, and that's basically a form of dizziness, and anxiety. We also want to consider, does the patient have effects of polypharmacy? Polypharmacy just meaning that they're on so many medications. Generally, once a patient is on 6 or more medications, it's very difficult, if at all possible, to predict the pharmacokinetics of how those drugs interact with each other. We are very knowledgeable about measuring liver function and kidney function, and we do have plenty of guidelines and ways to mitigate effects of medications if the patient, for example, does have kidney failure or kidney disease. But still, we need to look at the list afresh and consider whether or not the patient's suffering from polypharmacy, and that needs to be remedied itself. And then we also have to consider the adverse effects of chemotherapy. Chemotherapy is a common treatment for certain cancers. So examples of treatments might be dexamethasone. That's a steroid, and that can improve pain, nausea, and appetite in cases of intracranial pressure or bowel obstruction. I don't think on this particular table it had the intracranial pressure mentioned, but you'll see it's mentioned right here. So central nervous system, example would be increased intracranial pressure, cerebral edema, edema meaning swelling, so pressure and swelling. And this might occur, for example, with primary cancer in another organ that has spread to the brain, and we call that brain metastases. And right here, this word corticosteroid is a general term, and dexamethasone is a specific term for a steroid that's given in this particular case. We don't have enough scientific evidence to recommend the antipsychotic haloperidol for pain, nausea, and appetite, and we don't have enough scientific evidence to recommend cannabis for nausea and vomiting. We do have evidence to recommend cannabis for pain, and we do have evidence to recommend haloperidol for psychotic problems. But this particular example I'm giving is pain, nausea and appetite. Causes of anorexia, which is loss of appetite, that can be treated, include xerostomia, which is dry mouth, nausea, constipation, side effects of medications. So patients, but especially their families, have a deep fear that the patient will starve to death if they don't eat. And if you think about it, that really does make sense because eating is so central to our day-to-day activities of daily living. It's very disconcerting when we see a family member suffering with anorexia. They're just not eating. And then family members feel like their death is going to be unnecessarily hastened if we don't treat the anorexia, which is the loss of appetite. It can be a good idea to give medicine for anorexia or loss of appetite if the patient has more than a few weeks to live, and that's within the palliative care. We do have treatments. They include Megace or Megestrol. Side effects of Megace are gastritis and thromboembolism. So you have to have a shared decision making with the patient to make sure that they're okay being put on Megace. It's a liquid. Let me see if I can do a whiteboard for you. Okay. And then Reglan or metoclopramide, that's helpful for nausea. And then there's mixed evidence for other medications, including mirtazapine, olanzapine, cyproheptadine, and dronabinol. I really do want to get this whiteboard. Bear with me here. So you guys know I'm new to sharing the screen and I did practice the whiteboard, but I'm just going to have to do that another time for you. But let me repeat the medications. Megace, Reglan, mirtazapine, olanzapine, cyproheptadine are examples. Okay, so let's talk about delirium. That's a issue that occurs with chronic illnesses that might trigger a palliative referral. If the prognosis is days to weeks, say the patient has an advanced illness and they might not live past days or weeks, they might suffer from delirium. And symptoms include confusion, disorientation, perceptual disturbances, and then motor symptoms like they're not very active at all, or they're very active, or it's a mixed bag. Usually family members can tell the difference of their behavior. Causes of delirium include uncontrolled pain. So for that, I want to share another screen. And this happens to be medications that we might give if a person's inside of palliative care. And these are controlled substances. So we want to control pain. The person might have the symptom or diagnosis of delirium if they have infection. Also, if their oxygen level is very low, a good example would be a patient with COPD, which is chronic obstructive pulmonary disease or chronic lung disease. I did do a video on this for basic COPD, so please, you can type in Lara Tigler COPD and you should find that. Medication effects. So there are plenty of medications where there's a possibility of delirium. And again, that goes to medication review with each time you see your provider. Another cause of delirium is constipation. And I just want to go over the symptoms of delirium one more time, because I think that's a new word for some people. Confusion. And you know your family member. So if you say they're acting confused, disoriented, they don't know where they are, they don't know who you are. Perceptual disturbances, they just don't perceive what you're perceiving. And motor symptoms, either they're more active, less active, or some combination that's unusual for them. So the treatment for delirium is not medication. We want to reorient the patient. We want to preserve their day-night cycle. And we want to discontinue any unnecessary medications. I'm going to go over this one next, and you can see delirium is right here. So please start looking at that. And there is an article in the American Family Physician Journal dated in the year 2023, specifically about medications that are appropriate to treat delirium. So a palliative referral is appropriate with conditions that basically I mentioned earlier, and those include cancer, organ failure, dementia, ALS, and stroke. Also, palliative referral is appropriate if the symptoms that the patient is having are not responding to treatment. Also, if the symptoms are beyond the primary care physician or oncologist expertise and comfort level. So basically, a palliative doctor is a specialist in and of themselves, and they have a lot of experience with providing treatment and care specific to conditions I mentioned earlier. Sometimes a person might have delirium and it's going to be part of a terminal condition. So the palliative physician would be consulted to provide sedation that's appropriate for that patient. I wouldn't say long-term, but it's going to be over a period of time. So you need an appropriate level of sedation for a long period of time, not just a one-time treatment. Palliative referral might be appropriate if there is an uncertainty about prognosis. So as you know or might know, when you're diagnosed with cancer, you're usually given a stage and a percentage survival number, say at 5 years. So patients with this condition, X number of percent will survive with treatment by 5 years. But then sometimes we don't have exact numbers. The prognosis is uncertain. And it might be that if it is uncertain and the treatment burden is great, or the patient really wants to focus on quality of life, then that's where a palliative referral is appropriate. Also, a palliative referral might be appropriate if there's significant distress with patients and their families, whether it's emotional, psychosocial, or spiritual. So a good example, I can think of a patient I have that has heart transplant. She's doing pretty well, but she has a significant level of baseline distress just because of the ongoing medications, potential complications, and specialist appointments that she has to go through. And it's such a heightened level of distress. So there might come a point where the patient wants to, for lack of a better phrase, pick and choose their treatments and not necessarily go aggressive for every single treatment because the distress is beyond her ability. Or another patient I can think of, the spouse has Alzheimer's dementia and the only caregiver is the husband, and he's doing a great job, but the condition of Alzheimer's dementia progresses. And there's really only so much one person can do. You might want the patient to stay at home, and that's wonderful. Let's say you've been married 60, 70 years and you want to stay together till the end, whatever that might be. But it comes to a point where maybe the spouse realizes they just physically cannot do the job anymore. They might be the same age as the patient, say 90 years old. They might have some medical conditions themselves, and they've reached the limit of their ability to care for the patient. In other words, their distress level is just way too high. So depending on multiple factors, they might choose palliative care. Or in that case, I'm giving you a placement to a memory care facility. Okay, so I'm going to go over these tables that I'm showing you to give you some high points. So we're going to go over some disease examples, examples of cardiac disease, lung disease, kidney disease, cardiac, lung, kidney, liver, brain, and neoplasms or cancers. So let's go over heart conditions that might make it appropriate to refer to palliative care. Congestive heart failure, ischemic heart disease, and as I did mention in a coronary artery disease video, I think the general population might automatically think that either you have heart disease or you don't. Like it's black and white. You have a heart attack or you don't. And I think what I've seen through the years is that patients don't always realize that coronary artery disease itself can cause ongoing symptoms and can progress. Transplant rejection, and remember I was telling you about that patient who had a heart transplant, and it's basically a fight every day to prevent rejection of the organ that came from the donor. Complications of left ventricular assist device. I think a lot of patients out there listening or family members of patients who have had pacemakers inserted or defibrillators also can understand that having a device inserted in your body to prevent sudden death, for example, like say, for example, from ventricular defibrillation, or sudden death from, say, a heart rate that just can't get above 30. So the patient needs help with a pacemaker to keep their heart rate up to a certain level. That has its own treatment burdens and complications. Okay, let's move to lung disease. So I mentioned chronic obstructive pulmonary disease, interstitial lung disease. That's a phrase that you might not at all be aware of, and that's okay. You can see it's right here if you want to screenshot your phone. Transplant rejection again, and cystic fibrosis. Okay, let's go to kidney disease. So chronic kidney disease, that's a condition that I did a series of videos on, and that's actually how I started my channel. And I do encourage you to go look at and listen to those videos. I actually encourage you to listen to these videos more like a podcast rather than me being a YouTuber. I think of myself more as a podcast. So you can play it in your car, say when you're commuting to work, or play it while you're in the bathtub or shower, or some kind of time where you can multitask and kind of get to hear some of these facts. Okay, let's go to liver disease, end stage liver disease. So in the quote old days, I think most of us, our minds would go to someone who suffers from alcoholism. Very common to suffer from end stage liver disease, but now we're seeing end stage liver disease in other conditions as well. So, for example, as Americans have been getting heavier and heavier and heavier, we're seeing diseases of the liver related to obesity. It can also be for other reasons too. Transplant rejection as well. Neurological disease includes amyotrophic lateral sclerosis, ALS, dementia, Parkinson's disease. The incidence of Parkinson's disease is increasing, and that Parkinson's disease carries an incredible burden for the patient and their family. I can do a video on that another time. I definitely will do that. And then stroke. I mentioned stroke earlier. And finally, neoplastic disease, which I think many people listening to this particular video will be curious about palliative referral because either they have cancer or their family member has cancer. That's a very common reason to do a palliative referral. So examples would be advanced neoplastic disease, which just means that the cancer has spread. There's really no hope of the patient living without a diagnosis of cancer. It's going to continue or worsen. Example would be lung cancer, for example, anemia from cancer. This is just to educate the viewers out there that we can have serious chronic illnesses as consequences of another chronic illness. And this is just a good example. Anemia from cancer. There could be anemia from chronic kidney disease. There are many chronic conditions that relate and are associated with or due to other chronic diseases. And then in my videos previously, and then I'm sure in subsequent videos, I'll give you plenty of examples of that. Chemotherapy and pneumonitis. So that are disease examples. I do want to do a little bit about pain control, but I'm not going to go over all of these tables in detail because you can kind of see them and screenshot them. But if you have mild pain, you might consider acetaminophen, which is the generic of Tylenol. But being a senior specialist, I actually don't even encourage my patients to reach for an oral medicine, even if it's acetaminophen. Try your best not to take medications if you can. But of course, please take medications if you need it. Under a competent doctor's care like myself, there's really no reason to suffer. We can manage pain, but we want to do it in a smart fashion. Consider use of adjuvant medication specific to type of tissue damage involved. So NSAIDs means non-steroidal anti-inflammatory drugs like ibuprofen and naproxen. Corticosteroids means prednisone, dexamethasone, and the corticosteroids might be appropriate for bone pain. The gabapentinoids, an example of that would be gabapentin. And that's a medication that decades ago we used to control seizures, but then we since learned that it's very helpful to control neuropathic pain. Serotonin, norepinephrine, reuptake inhibitors. A common example would be Prozac, but there are many others. Tricyclic antidepressants are very effective for pain. It's just that they can have sometimes significant side effects with the elderly population. So you have to have a provider or doctor who's very knowledgeable about these medications. So for heart disease, you'll want to use some medications that relieve angina pain. And that's pain in your chest or elsewhere in your body. That's because of the coronary artery being somewhat blocked. The blood flow just can't get through to the muscle tissue on the other end. You'll want to consider volume control to decrease edema or swelling. So for example, heart patients might have significant swelling in their legs, and swelling in the legs causes significant pain. Opioids are basically like the controlled substances that you hear about in the news, like fentanyl would be a good example of really a street opioid. Um, and it is causing quite a lot of problems. But there can be example of other opioids, and let me just go find that for you. Morphine, I think that's common in the culture to understand that word because it's mentioned in popular movies and TV shows. Hydrocodone is a relatively mild narcotic. It might be a starting uh, narcotic. Hydromorphone, oxycodone, and then non-narcotic controlled substances include lorazepam and clonazepam. They're just included here because they're controlled substances and they have their own indications. So notice how pain is the main indication for the narcotics, these top four medicines. Also, shortness of breath. Dyspnea just means shortness of breath. But for the lorazepam and the clonazepam, which are benzodiazepines, a primary indication would be anxiety, but also dyspnea, which is the shortness of breath. And right there, you see the row that's labeled dyspnea. So we do have medications and ways to treat shortness of breath. I told you about nausea and vomiting treatment. Constipation is very important to treat constipation. If you suffer from constipation, it alone can cause other problems, which can be quite serious. Anorexia, we talked about delirium. And at the bottom, depression and anxiety. So it's not uncommon for a patient who has a chronic illness to suffer from depression. Or it's not uncommon to have anxiety about many doctor appointments, procedures, imaging. So we do have ways to help with that. And we want appropriate ways to help with that. Okay, this is the end of the medical information. I want to go ahead and switch gears to spiritual information. And actually, that's a good connection to palliative care because the patient or the family might have spiritual distress. Remember how I was telling you that the treatment burden or the symptoms might be to such a high degree that it causes the patient and their family such significant distress that it warrants a palliative referral. And the same can be true with spiritual, like the anxiety of dying and what happens after we die. So yeah, let's move over to the spiritual information. So this is the point where if you don't want to stay for the spiritual information, you should click away. But first, please do like and subscribe. Okay, so many of you know that I am a devout Christian. I am not trying to proselytize or turn you into anything. But I myself am saved and I do attend church regularly. I have found on a separate note that patients who have a spiritual discipline or a religion or a faith or even close family ties, they seem to do better anecdotally than the patients without those things. And then the scientific literature does seem to bear that out to some degree. So I just wanted to mention that observation I've seen through the years. But in regards to salvation, I feel like the general population, if they don't attend church regularly or they didn't grow up with any faith, which is not necessarily an uncommon thing, they might, if they hear the topic of salvation, they might think, well, save from what? You know, I'm doing fine. I think that's just a common thing that people might think, and they might ask about if they even do ask. So I wanted to go ahead and point you to the Bible. And I'm going to use a whiteboard here. You guys are going to be so impressed. Okay. And let's see. I don't use the whiteboard classic. Let's do that. Okay. So you might be surprised, but in the Bible, it does teach us about serpents. And you might remember that from Sunday school if you went. And even dragons. Yes, that is in the Bible. So I encourage you to do your Bible reading. And remember that YouTube channel, actually, it's much more than a YouTube channel, that I taled about, bibleproject.com. You can actually type in YouTube Dragon Bible Project, and you'll see a quick video explaining the different parts of the Bible where you see references to the serpent or the dragon. And this is a mysterious, say, power of Satan, let's say, that has affected humanity. So God made us perfect in his image. We were living really almost as equals with God in the Garden of Eden. And then the serpent came along and tempted us, both Adam and Eve, and quite clever serpent. And we fell from grace. Um, so the reptilian or dragon is playing some sort of very significant role in our spiritual process or hindering our spiritual process. So I'm just giving you a clue as to, because you might hear the word devil or the devil made me do it or the details in the devil is in the details. So I think popular culture, you're going to hear the term devil, but you might not really hear or be knowledgeable that the term dragon is in the Bible. So I do want you to be aware of this connection with the dragon or reptilian, the serpent, to um, our fall. And so, what are we being saved from? Yeah, you might say the devil, but I would actually say, I would just say overall, both of these things, or say many things, like you might think of demons as well. I would just kind of put it all in the same group, which is the power of Satan, which is Satan is like a force. It's not really like a person. Um, And the good news is, and this is where the Christianity comes into play. And like I say, you don't have to be a Christian, but there are plenty of religions in the world that have they have similar paths to salvation. Or I'll say it differently, they emphasize the importance of being saved. This is true of Hinduism and many other religions. And so I would say that, yeah, it's urgent to be saved, and that you need to kind of think about what exactly am I being saved from? What happened to me? And how did I fall from grace? And how do I get back to who I really am? And so the good news is you can get back to who you really are. You really don't have to be afraid of any of these things. Um, these the power of Satan, it doesn't have control over your destiny. I mean, unless you give it control, I suppose, but it doesn't have real power over you. As long as, like from my Christian standpoint, you are a follower of Christ and you give your allegiance to the Lord and the Savior. And then study and study and study. Like it's just not, in my opinion, enough to kind of know some of these terms. But I do encourage you to go to BibleProject.com. I have no connection whatsoever with that organization. I just have found that they have excellent factual information and beautiful artistry. Okay, so that is the end of our discussion on palliative referral, palliative care, and the spiritual information. Thank you so much for staying tuned with me today, and see you next time.